the roundtable discussion was particularly, I thought, productive, and it was a privilege to be part of it. It was chaired by Professor Mohamed Moti and Philippe Moreau, and it was a wonderful conversation around the evolving position of upfront treatment in transplant-eligible patients. And we really discussed how in healthcare systems like the United States, where multiple salvage options exist, thank goodness, patients can reasonably now think, if they're transplant eligible, that they can collect stem cells and keep them in reserve and use them later with transplant, which involves obviously high dose melphalan and stem cell support at a later date if they need it. But for a significant number of patients, this sort of collect and wait and see approach is justified based on the current data, because the success of the upfront triplets and now quadruplets, which involve a PI, an IMiD, steroid, and or an antibody, are so encouraging that this ability to allow transplant to be kept in reserve is becoming something that we think is very reasonable for patients to consider, not least of which because randomized data are not showing survival benefit to early transplant over late. And we have important data coming at ASH in December, which is going to further examine that from our French partners in the IFM as part of the IFM DFCI 2009 project. And so that information, I think, will be particularly important to the field. But the roundtable also emphasized that in countries where salvage options are not necessarily so widely available, the importance of using early transplant to minimize the risk of disease control being lost at a later date and the consequences thereon was a very good point that was made by Philippe, and I fully endorse his point, which is that if you're in a healthcare system where salvage options are more limited, the use of early transplant may be wise. There was particularly important contributions from Francesca Gay and indeed also Graham Jackson as we fleshed out the ideas around maintenance and what maintenance means. And Francesca raised a very important point of, in her really, I think, landmark study from the Italian group, examining KRD versus KCD, and what she's showing is the combination of carfilzomib, Revlimid, and Dex for 12 cycles with or without a transplant is extremely effective. However, very interestingly, in the high-risk population, the use of the transplant may in fact be important. And I think that's incredibly interesting because it points to the importance of a tailored approach to a patient. So in other words, if a patient has standard risk disease, does really well with induction remission therapy, and you can maintain them on a combination of a PI and an IMiD, you're probably just fine if you can keep the stem cells stored and watch them carefully. However, if you have high risk disease, you have to be a little careful. And the question then becomes, do you deploy transplant? Or actually now, with a triplet plus an antibody, is that the best platform for that patient to pursue? And we discussed important data in that regard, not only from the Griffin study, which was a privilege to be part of, led by my colleague Peter Voorhees, and we showed there that the combination of RVD-Dara was exquisitely active, and if you combine transplant with it, very impressive. Key question is, can RVD-Dara do the same thing? And we've got a wealth of data from KRD-Dara, led by investigators here in the United States, including Dr. Luciano Costa and in a separate study, Dr. Ola Lundgren. And Luciano has shown in his studies that transplant plus KRD-Dara gets very high quality responses and remissions. But very interestingly, with all the cautions of cross-trial comparisons, Ola's showing in his work that KRD plus Dara without transplant is achieving the same level of MRD negativity as a research tool, showing in this setting the potential for clinical benefit. And what I mean by that is MRD negativity used as a research endpoint in these studies is guiding us in very important directions. And I think that MRD negativity, for example, is a useful barometer of quality and duration of response in the studies. And also, of course, Francesca's work is making that point as well. But I think we have to be very careful because long-term follow-up is critical. I'm very impressed at the value of MRD as a research tool, but I also think the value of long-term follow-up and understanding the longer-term implications of these findings are key. But in a nutshell, we found in this roundtable that a triplet plus an antibody looks very promising. Transplant definitively has a role in younger patients, dependent on what salvage options are available and the risk profile of the patient. And going forward also, and this is a very important point from Graham, who's obviously been on the forefront of this, Graham Jackson, maintenance really matters. The duration of maintenance is critical, and what you put in maintenance matters. An IMiD backbone is probably the very least, and then what you add to that maintenance platform equally helps. So it was a very fruitful discussion, and I think very informative for the myeloma community in terms of looking to the future and where we may be.